Biology of neurodevelopmental disorders. Spina bifida. Biology of neurodevelopmental disorders. January 24, 2008. Chris Chaplow. John Hammond. Spina bifida, what is it? What causes it? How can it be prevented? How can it be managed? Social impact. Further information. Spina bifida, what is it? What causes it? How can it be prevented? How can it be managed? Social impact. Further information. What is spina bifida? Split spine caused by incomplete closure of the neural tube, usually in the lumbar or sacral region. What is spina bifida? Worldwide incidence is 1 to 2 cases in 1,000 births. US incidence is 0.7 per 1,000 live births. East Coast higher than West Coast. Slightly higher incidence in Caucasian population. Irish immigrants also have a higher risk. Seen more in children born in late summer and early fall. What is spina bifida? Anatomy review. http://www.notebook.com/lumbarspineanatomyvertebra.gif http://thespine.net/article/lumbar decompression_files/image001.gif. What is spina bifida? Anatomy review managers. Dorland's Medical Dictionary. What is spina bifida? Several classifications that vary in severity depending on location and extent of opening. Spina bifida occulta. Spina bifida cystica. Meningocele. Myelomeningocele. Spina bifida ventralis. What is spina bifida? Spina bifida occulta, hidden. The bony vertebra is open, but the spine is within the spinal canal. The skin may have a lipoma, small benign fatty tumor, some discoloration, birthmark, or a small tuft of hair overlying the spinal defect. Most patients with spina bifida occulta do not know they have it. There may be tethering of the spinal cord. What is spina bifida? Spina bifida occulta, tethered spinal cord. Often occurs later in life. Caused by limitations of movement of the spinal cord within the spinal column. Patients often have low back pain, weakness in the legs, and or incontinence depending on the site of tethering. http://www.uwealth.org/images/ubedicpro2/upload/6001_figure_1.jpg. What is spina bifida? Spina bifida cystica, meningocele. The bony vertebra is open, part of the meninges is protruding out of the spinal canal. Since the spinal cord is not protruding, there is often normal function. Some cases of tethering have been reported. What is spina bifida? Spina bifida cystica, myelomeningocele. The bony vertebra is open, part of the meninges and part or all of the spinal cord is protruding out of the spinal canal. Since the spinal cord is protruding, it is often not fully developed. Involved nerve roots are often not developed, resulting in weakness, pain, and or paralysis. What is spina bifida? Spina bifida cystica, myelomeningocele. Arnold-Chiari malformation 2 is often associated with myelomeningocele and occurs when the cerebellum is forced downward. This can result in life-threatening situations because the buildup of cerebrospinal fluid can cause pressure on the brain. Patients with Arnold-Chiari malformations often require placement of a shunt to drain the excess fluid. http://www.thefetus.net/images/article/images/central_nervous_core-systems/arnold_chiari_files/image001.jpg. What is spina bifida? Spina bifida ventralis, anterior opening. Much less common than other forms of spina bifida. Meningeal sac will protrude into the retroperitoneal space and impinge on retroperitoneal organs such as the duodenum, ascending/descending colon, kidneys, adrenal glands, pancreas, aorta, and inferior vena cava. http://myweb.lspu.ac.uk/dirt/museum/margaret/871-3398-208-2230.jpg. Spina bifida, what is it? What causes it? How can it be prevented? How can it be managed? Social impact. Further information. What causes spina bifida? The exact cause of spina bifida is unknown. All research to date has indicated both a genetic and environmental influence. The developmental process that results in spina bifida is well studied. Cortical gray and subcortical injury, genetic. White matter injury. Neuronal migration. Cortical gray and subcortical injury. Genetic. Lin, J. P. J. Neural Neuropsych Psychiatry 2003 /74:23 I-29 I. Copyright 2003 BMJ Publishing Group Limited. What causes spina bifida? Developmental biology, 6th ed. Stages in the closure of a xenopus neural tube. Video views and reviews, neurulation and the fashioning of the vertebrate central nervous system. Christopher Weathers. What causes spina bifida? What would prevent the neural tubes from closing properly? Phthalate seems to play a large role in the closing of the neural tube, but it is unknown exactly how phthalate works in this process. Phthalate influence was discovered by the increased incidence in spina bifida seen in Irish babies born in late summer and early fall. The lack of leafy green vegetables caused the mother to have low levels of phthalate during conception. Genetics also play a role in the development of spina bifida. Mothers with one child with spina bifida have an increased risk of additional children having spina bifida. Studies with phthalate-resistant mice. What causes spina bifida? Valproic acid, Depakote. Oral medication used to treat seizures/convulsions, migraines, and bipolar disorder. Mechanism of action, thought to increase GABA levels in the brain. Pregnant women taking valproic acid have an increased risk of having children with spina bifida. Spina bifida, what is it? What causes it? How can it be prevented? How can it be managed? Social impact. Further information. How can spina bifida be prevented? Education. Phthalate intake. How can spina bifida be prevented? Education. Neural tube begins to close at day 22 after conception. Neural tube is usually fully closed by day 28 after conception. How can spina bifida be prevented? How can spina bifida be prevented? Phthalate intake. Recommended that women of childbearing age take 400 micrograms of phthalate per day. Pregnant women should take 600 micrograms of phthalate per day. Women with a previous child with spina bifida should take 4,000 micrograms of phthalate per day. Phthalate can decrease the risk of spina bifida by up to 75%. How can spina bifida be prevented? Sources of phthalate. Vegetables and grains. Many foods are now enriched with phthalate. Most multivitamins contain phthalate. Some vitamins are specifically formulated for women. Spina bifida, what is it? What causes it? How can it be prevented? How can it be managed? Social impact. Further information. How can spina bifida be managed? Treatment for spina bifida depends on the extent of spinal cord involvement. Spina bifida culture usually requires no treatment unless pain from tethering develops. Meningocele usually requires removal and early management of the cyst. Myelomeningocele usually requires the most extensive treatment, but treatment is variable. How can spina bifida be managed? Lesion level. Above L3. L4 and below. S1 and below. S3 and below. Spinal-related disability. Complete paraplegia and dermatomal paranenesthesia, bladder incontinence, non-ambulatory. Same as for above L3 except preservation of hip flexors, hip adductors, knee extensors, ambulatory with aids, bracing orthopedic surgery. Same as for L4 and below except preservation of feet dorsiflexors, and partial preservation of hip extensors and knee flexors, ambulatory with minimal aids. Normal lower extremity motor function, saddle anesthesia, variable bladder ectoincontinence. How can spina bifida be managed? Detection. Antibiotics. Surgery. Careful observation. Physical therapy. How can spina bifida be managed? Detection. Triple screening. Maternal blood test for A-fetoprotein. Ultrasound for bone defects. Amniocentesis. A-fetoprotein is elevated in 75 to 80% of cases of spina bifida, myelomeningocele. How can spina bifida be managed? Amniocentesis, using a needle to collect amniotic fluid. How can spina bifida be managed? Antibiotics. In some cases the spinal cord is exposed to the environment. Antibiotics are essential in preventing infection of the SNES. How can spina bifida be managed? Surgery. In some cases the spinal cord is exposed to the environment or tethered. Surgery is performed in order to cover the spinal cord with muscle and skin or to untether the spinal cord. In utero surgery has also become a viable option for some cases. How can spina bifida be managed? Careful observation. Children with myelomeningocele often have hydrocephalus, blockage of CSF. Children may present with paralysis, blindness, MR, inability to speak, convulsions. Any changes in mental status or behavior should be quickly brought to the attention of the child's physicians. How can spina bifida be managed? Physical therapy. Spinal cord damage can cause muscle weakening and wasting. Speech therapy may also be useful for some individuals. Spina bifida, what is it? What causes it? How can it be prevented? How can it be managed? Social impact. Further information. Social impact. Prognosis and any deficits are dependent upon level of involvement. Estimates from 5 to 40% of the world's population may have spina bifida occulta. Meningocele is not very common and often has minimal impact once the cyst is removed. Myelomeningocele has the largest impact on patients and their families. Social impact changes with time. Before antibiotics, most children with myelomeningocele died because of infections in the SNES. Those that survived were unlikely to ever walk. During the 1990s, the discovery of the role of phthalate in neural tube closure drastically decreased the number of cases of myelomeningocele. In the late 1990s, in utero surgery was attempted to close neural tube defects. Social impact. Children born with spina bifida today require some special treatment. Multiple surgeries starting as early as 48 hours after birth. Physical therapy. Bowel and/or bladder surgery helps prevent infection and social stigmatism. Latex allergies are often present. In many cases, special centers are better equipped to treat children with spina bifida and have a variety of specialists on staff. Social impact. Most children that are treated early will have normal IQ and be able to attend public schools. Mobility is the biggest concern for many patients with spina bifida. Lack of mobility can lead to obesity and scoliosis. With proper treatment, individuals will live well into adulthood. Social impact. Notable people that have spina bifida: Hank Williams, Sr., singer. John Mellencamp, singer. Buddy Winnett, horse jockey. Bruce Payne, actor. Gene Driscoll, Olympian. Renee Kirby, actor. Further information: Spina Bifida Association, www.spa.org. UAB Health Systems, http://www.health.uab.edu/15521/ Local clinic Children's Hospital Spina Bifida Clinic No. 3 1600 7th Avenue South, Birmingham, Alabama 35233. Phone 205-939-5281. Website http://www.cis.org/ Paper segment Spina Bifida. The focus of the paper is what causes spina bifida. Genetic mouse models of spina bifida and neural tube disorders. How can spina bifida be repaired? In utero repair in humans. Curly tail, brief history. Curly tail is a spontaneous mutation that was first described in the UK, 1950. The CT gene is incompletely penetrant. Some individuals fail to express the trait, even though they carry the allele. Not sure what is the main genetic defect that leads to the curly tail phenotype. Curly tail, the phenotype. Curly tail mouse can demonstrate 0 to 3 different phenotypes. Healthy. Curled tail. Lumbosacral spina bifida. Exencephaly, brain located outside of skull. Curly tail, penetrance, incomplete. On average, 40 to 50% unaffected, 50 to 60% have some neural tube defects or curled tail. Curly tail, as a model for spina bifida. Causative. Mechanism. Cures. A mouse model of common human NTDs would have to contain the following. Have different degrees of defect. A degree of genetic complexity. Responsive to nutritional supplementation, inositol. Curly tail, what gene are involved? Inositol and folate-resistant neural tube defects in mice lacking the epithelial-specific factor GRHL3. Stephen B. Ding, Thomas Wilanowski, Alana Orden, Mark Hall, Ann K. Voss, Tim Thomas, Vishwas Parekh, John M. Cunningham and Stephen M. Jain. Ting et al. 2003. Based on studies in the Drosophila, the gene grainy head, GRHL, has been implicated in patterning of the nervous system. In addition, mutations in the fly have shown that defects exist in epithelial closures, which neural tube closure is. What role does mammalian GRHL have in neurulation? Are there any similarities between a knockout of GRHL and the curly tail mouse? GRHL3 expression. Is GRHL expressed in the developing mouse? In situ hybridization shows that GRHL3 is expressed in non-neural ectoderm that is adjacent to the neural tube. Does GRHL3 mutant mice have NTD? All embryos had spina bifida and curled tails. 2% had exencephaly. Problems in the bone structure. In the caudal region of the neural tube, the neural folds never occurred. The relationship between GRHL and CT. Can folate or inositol rescue NTD in GRHL3 mutant mice? Gustafsson et al. 2007. Further investigate if GRHL3 is the gene that is defective in the curly tail mutant mice. Investigate expression of GRHL3 in CT mice. Can defects in the neural tube be rescued in curly-tailed mice? GRHL3 expression is reduced in curly-tail mice, but the expression is rescued when GRHL3 is overexpressed. GRHL3 mutation in the promoter region exists in curly-tail mice. Rescue by overexpression of GRHL3. Conclusion. Mutations in curly tail mice seem to correlate with mutations in the promoter region of the GRHL3. Curly tail mice that overexpress GRHL3 show no defects in the neural tube. The phenotype in GRHL3 cannot be rescued by inositol. Further research, folate has reduced the risk of spina bifida. Can inositol be used in humans? Further research, do mutations of GRHL3 exist in humans that have spina bifida or other defects of the neural tube? Clinical paper. Can fetal surgery be used to correct or reduce the risk of neurological defects that exist in spina bifida? Looking at a group of papers from the Children's Hospital of Philadelphia. Why fetal surgery? Neurological defects in patients with spina bifida are not necessarily caused by the defect in neurulation, but caused by damage from injury or chemical-induced trauma when the fetal neural tissue is exposed and unprotected. Hypothesis is that surgically covering up the exposed neural tissue would improve neurological outcome. Fetal surgery has been used to improve neurological function in a sheep model of spina bifida. First evidence, 1998. 27-year-old woman, with a 23-week gestation fetus. Lesion in the thoracolumbosacral, T11S1 level, was detected at 20 weeks. In addition, alpha-fetoprotein was raised. Arnold-Chiari 2 malformations were detected. Good leg movements were detected in the fetus. Surgery, a low transverse maternal laparotomy and vertical hysterotomy were performed. Cystic membrane of the spina bifida lesion was excised and skin flaps were developed to close the defect and protect the developing spinal cord. Amniotic fluid was replaced with Ringer's solution. Uterine and laparotomy wounds were closed. Birth at 30 weeks gestation. A baby boy was born by caesarean section. Shunt tubing was removed. Leg function was excellent, good knee and hip flexion. Except for an absent plantar and a right club foot. MRI confirmed that the lesion was repaired and the Arnold-Chiari malformation was no longer present. No hydrocephalus. All developmental milestones were reached by 6 months of age. Developmental milestones. Approximately age 3 months, 4 to 5 months, 7 to 9 months. Motor milestone. Holds head up. Rolls front to back, sits when propped. Sits alone, crawls. 2003 protocol. 1998 to 2002, 50 patients underwent in utero fetal closure and were delivered. To be considered for this study, pregnancy had to be between 20 weeks and 25 weeks and 6 days. Demonstrate the presence of Arnold-Chiari malformation, type 2. Have a lesion at S1 level or higher. S2 or lower lesions were excluded because outcome were usually good. Intact neurological function of lower extremities. Absence of club foot. Surgical procedure and pregnancy management. Similar as before. After the surgery, the mother stayed in the hospital for 4 to 5 days. Discharged to the Ronald McDonald House and placed on bed rest with minimal physical activity. Delivery was performed at 36 to 37 by caesarean section. There were some births that occurred before this day. After delivery, the infant was admitted to the NICU for evaluation. 3 deaths, both very premature. Surgery does not affect gestational ages at birth. 2003 outcomes. Mean birth weight was within normal range. 2,354 grams, range 1,100 to 3,490 kilograms. All the surviving fetuses had reversal of Arnold-Chiari malformation, type 2. Leg function. 57% better than expected. 17% worse than expected.